I think it's still good morning, right? Good morning, everyone. Thank you for joining us on this esteemed and highly experienced panel. I invite you all to take the time to review their bios in the Summit app. I'm Simona Kwan. I'm from NYU School of Medicine. I'm an associate professor there. I direct our section for health equity in the Department of Population Health, and I also direct the Center for the Study of Asian American Health, which is a National Institute on Minority Health and Health Disparities funded center of excellence. I'm very honored to serve as a moderator on this panel on advancing health equity. I will turn to each of our panelists and ask them to introduce themselves, their affiliation, and we'll start off with one or two sentences on key work that they are doing in the health equity and innovation space, centering our Native Hawaiian, Pacific Islander, and Asian American populations.
Good morning, everybody. My name is Nishith Pandya. I am Director of Federal Relations at the American Cancer Society Cancer Action Network. We are the advocacy arm of the American Cancer Society, which is our more famous cousin, we call it. In my portfolio, I specifically focus on FDA and tobacco issues. And a couple of things that we're working on as an organization, of course, is increasing equity, but really what that means is increasing access to care, screenings, prevention, and diagnostic treatments, as well as treatment of cancer itself. And we also want to make sure that the access is equitable and accessible for everybody across the country to join in our mission of ending cancer for everyone. And so we have a presence and a footprint in all 50 states, in Guam, Puerto Rico, and we really try to leverage and activate our grassroots and our staff networks to make sure we can fulfill our mission. Thank you for being here.
Good morning. Happy Native Hawaiian, Pacific Islander, and Asian American Month. I'm honored to be here today. My name is Alisi Tulua, and on my bio, I am the project director of the Native Hawaiian and Pacific Islander Data Policy Lab, which is housed at the UCLA Center for Health Policy Research. Today, I'm actually, I have transitioned out of that position, and I'm currently the program director at a new startup foundation called Asian American Futures, overseeing our work in California communities and also our NHPI initiatives. All that to say, I was invited to be on this panel because of the work that I was doing at the lab, which I will continue to do as a volunteer, recognizing the importance of data equity, especially for our Native Hawaiian and Pacific Islander populations. And that entity was created in the midst of the pandemic because of need from community organizations for COVID data that was disaggregated for our communities. And so our very first project was driven by volunteers who founded the lab, who scraped national state COVID dashboards for the states that disaggregated NHPI data and pulled it together into a data dashboard. And since then, the lab has created several other dashboards that has NHPI data. We recently launched a social determinants of health NHPI California county level data dashboard. And really the goal is to make data more accessible for NHPI organizations who are on the ground and need data to justify grant proposals, to justify legislative advocacy. And so the work of the lab is to really support that and also partner with institutions, data systems to advocate for data to be more equitable for our populations. And hopefully I'll be able to share something that will be useful to the work you all are doing. Thank you for having me.
Hi, good morning. I'm Dr. Tanya Vinton. I'm an obesity medicine specialist from Dallas, Texas. I'm double board certified in internal medicine and obesity medicine. I'm currently the medical director for the weight wellness program at UT Southwestern at Texas Health Dallas. And I'm also the president and founder of the Dallas Obesity Society, which is a nonprofit organization dedicated to educating clinicians on obesity and treatments for obesity. And I'm specifically here today to talk about obesity as a chronic medical disease condition and how it affects the API population. As you all may or may not know, obesity is a chronic medical disease condition. There are a lot of neurohormonal endocrinopathies, fat mass forces that can then lead to 240 plus medical diseases. Specifically, we've used BMI to diagnose obesity in the past, greater than 30, but specifically in our Asian population, this is actually much lower, where overweight actually starts at a BMI of 23 and obesity starts at a BMI of 27. And also what we have seen is that there's a disproportionate amount of disease, metabolic disease, that's associated with adiposity, excess fat in Asians, such that 48% of Asian Americans are thought to have prediabetes or diabetes. And South Asians specifically are at really high risk for early cardiovascular disease, up to like 2 times higher than our Caucasian counterparts. So I'm here today to increase awareness about obesity and hopefully talk together about ways to tackle this problem together. Thank you.
Thanks, Dr. Vinton. Hi, everybody. My name is Sean Kalaskar. I'm the Public Health Informaticist for the Alexandria Health Department as part of the Virginia Department of Health. As a practitioner inside of the Public Health Network, our biggest responsibility is to be the providers of last resort for our underserved communities. So it's individuals that are uninsured, underinsured, or don't have great access to primary specialty care. And so my role is to take a lot of the lessons learned as well as the new technologies and technological tools that we developed during the COVID pandemic and apply them to the rest of the public health portfolio that our Department of Health services. So that's both communicable diseases like STIs or respiratory illnesses, but then also non-communicable diseases like respiratory issues or COPD or obesity within the underserved populations. And so I'm honored to help kind of participate in this conversation, talk about some of the things that we're doing in public health in Virginia, but then also learn about what the next things that we can do, because I think it's a never-ending battle for public health to reach the communities that have not been spoken to before.
Thank you so much, everyone. And as you can see, we have a very multi-sector panel here, and we want to really get into some of the strategies that they're using across their different groups, agencies, and organizations. So I'll start with the first question. What strategies are you using to equitably engage Native Hawaiian Pacific Islanders and Asian Americans, and how are they're represented in population health advancements? This can include in clinical trials, but also in considering factors such as language justice. Nishith? Sorry.
So I mentioned our volunteer base, and one of the things we try to do is activate the volunteers from various communities to speak to their own communities. It's always better received if the person you're talking to is someone who can relate to you, who you can relate to, versus an outsider coming in and saying, you should do this. And especially for communities of color, there's been too much of you should do this from outside individuals. So somebody from their own community, somebody who can really have cultural empathy and understanding is always better. And we try to activate those volunteers where possible. That's on the grassroots kind of organizational side. On the policy side, you mentioned clinical trials. We've really been advocating for diversity in clinical trials. Last Congress, which was the last 2 years for those who are not in the Beltway bubble, we advocated for and were partially successful in the Diverse Clinical Trials Act. And this is a bill that law now that would increase diversity in clinical trials through both systemic and financial side of things. The systemic FDA governmental side was passed into law, and we were speaking earlier before the panel began that the funding, as always, is an obstacle, but FDA is working on updating regulations to increase the diversity of clinical trials, and we, as an organization, are working with other organizations and our coalition partners on the second half to make sure that people aren't penalized for participating in trials and to increase diversity and accessibility of those trials also.
Dr. Vinton? Thank you. So one of the main barriers to treatment for Asian Americans in excess weight, I think, really lies in dietary strategies. When we look at dietary strategies that are out there, like commercial programs, Weight Watchers, Jenny Craig, and even evidence-based strategies like Mediterranean diet, frequently these are not really appropriate or palatable for the Asian population. And with that in mind, I think a lot of these strategies that we have to have really need to be targeted, like clinics for our Asian population. At UT Southwestern, I'm proud to say that we recently had the development of a clinic called the South Asian Metabolic Clinic that's run by one of our preventative cardiologists, Dr. Rohaki, who's one of my colleagues at UT Southwestern. They're able to really have individual conversations with patients about dietary strategies for the South Asian populations, such as ways to decrease use of ghee in preparation of foods, ways to increase protein intake, reduce dietary starch, and then also increase physical activity, such as, say, through yoga instead of more traditional ways of getting increased physical activity. With that in mind, because it is a focused group, they are also able to do a lot of cardiovascular testing, so CT coronary testing, stress testing. So within this clinic, they're also going to be able to create a lot of good clinical data targeted to South Asians. And I think this is really a great approach that other medical institutions should follow in order to improve access to care for our Asian population.
I'd also like to add to that question, how do we make sure that our organization and the work we're doing is being accountable to the DEI work? How are we measuring, how are we tracking some of these strategies to make sure that we're equitably engaging our communities?
Yeah, so Dr. Kwan, thank you. I think one of the things from a public health perspective has been the accountability piece has been difficult, to say the least. But I think that with the conversations that are ongoing and also some of the changes in public health leadership that's happening, right? So I think we're having a generational shift in terms of the public health leaders that occur that exist at the federal level, at the state level, and at the local level, in which not only diversity, equity, and inclusion is a goal, but it is now the objective of the department to create the metrics around it. And I can say that right now it is definitely a struggle because the implementers of diversity, equity, and inclusion when serving our population are our practitioners. And it's already very hard to hire and retain public health nurses, population health practitioners, health informaticists, or any number of the roles that serve in the public health department. And so not only do we have trouble retaining these individuals, but we have to make a concerted effort to then implement training programs, awareness programs for these team members that are coming on. And then as they're hired away, we have to kind of start over from ground zero. So part of what we're trying to do is ensure that these components, this conversation about health equity, this conversation about health access, understanding and meeting patients kind of where their language needs are, so that we're not only communicating in like our top 3 languages, but understanding where they're at and making sure that we have translation services that are on demand and available. And it's a real person, that we're not kind of like, while I love Google Translate is not the most effective solution in a medical setting. It's not the most effective solution when you're trying to build an emotional bridge between yourself and an underserved population that already has trust issues. So you want to use a real live human translator or have those language resources in-house. And so we work to identify and recruit talent that has that, retain that talent, and then supplement their training. But I'll say it's definitely hard, and it is definitely something that we continue to work on and try to work and figure out what are the metrics for how we're doing it, and then what can we do to push those metrics higher.
Lacey, do you want to add any?
Sure. I think with a smaller population like ours, it's hard to think about how metrics for DEI is implemented that is equitable to our population. And so I think that the other challenge is that we continue to be in these institutions under the API label. And so there's an assumption that if there's an API person, that they are responsible for all of us and everybody. And I think that there is room and opportunity for work in DEI space to educate anyone that might fall under the API space about the diversity of our community, so that even when somebody like myself is not in the room, my interests are continued to be considered by the person that's in the room under the API label. And I can say that as an NHPI person. I can say that also, I'm sure it's the same struggle with many of our Southeast Asian communities that are smaller and also can't be in every room. So I think that the work a lot of our organizations are doing at the national level, providing leadership development and opportunities for there to be cross-learning across our communities, can contribute to the DEI metrics that are being captured to make sure that all of our communities are heard and represented.
Nishith, did you want to add anything about the data disaggregation, the data diversity in clinical trials?
Yeah, so one of the biggest obstacles to successful clinical trials is diversity of population, and like Alicia mentioned, it's everyone's just lumped in as one group. And we've heard some examples already of how different even AAPA and HPI groups have different needs and different just ramifications of social construct kind of thing. So, we've been pushing for data disaggregation. There was a letter that I always mix up the names, so I gotta think about it. There's a letter to OMB that a lot of groups signed on to talk about data disaggregation in the community, and this is a wider look than just AA and HPI communities, but this is something that needs to be done because this is something that all communities are facing. We've signed on to that letter to support that. We've looked at our own data to see how we can do the breakdown, and in past cases, some of the data there isn't enough other data along to break it down. We're looking how to make that better going forward, but this is something that matters because there are real world ramifications on the clinical trial side. Different ethnic and racial groups are affected by drugs in a different way. You'd think an aspirin would work the same for everybody. It doesn't, unfortunately. And then in some cases, some of these ramifications can be deadly. So you really got to know how a drug is going to impact certain people in certain groups, and you need diversity to do that. And so we're really pushing for that. And one of the things I mentioned in terms of the outstanding piece of the diverse clinical trials bill is the financial impact to patients and individuals. Right now, if you participate in a clinical trial and the manufacturer reimburses you for parking or a hotel or any countless incidental costs that come up, you can be taxed on that. It counts as income from the federal government's perspective, and you're penalized really for participating, which is a huge disadvantage for a lot of people. It's a huge discouragement for a lot of people too. So, and one of the most underrepresented groups in clinical trials are communities of color and low-income populations. Both groups that tend to be discouraged by getting taxed for something when they're trying to do a greater good. So we're working again with partners to fix this remaining portion of the bill. But the other part with clinical trials is that too many people who are recruiting for clinical trials are focused on getting the no's to say yes versus reaching out to those who've never been asked. And a lot of people have never been asked, especially for seniors, low income, and communities of color, are never going to be asked. But if somebody down the street has said no, they'll focus on getting them to say yes, and that's less likely to happen than somebody saying yes who's never been asked before. So, sorry.
Thank you, Nishith, and really appreciate you bringing in the data disaggregation piece to it. And to add more context, the COVID pandemic has really put a magnifying lens on the limitations of our data systems locally, regionally, and federally, who's captured and who's left out. So I would like to ask the panelists, what are some best practices and strategies your organizations or in your work have you identified for implementing and advocating for better disaggregated data moving forward and for recategorizing existing data? Now I'll ask Nishith already started us off, but Sean and Alisa.
Yeah, so I think, excuse me, I think data disaggregation is a phenomenal effort, and I think public health is behind the ball on it, primarily for a large reason that Dr. Kwan laid out. Prior to the pandemic, we did not have the appropriate data architecture, nor the teams that are doing the appropriate data engineering to ask for that data, to capture that data, and to record that data in a way that we could utilize it for further data analysis. For example, a lot of the vaccine administration systems, as well as like encounter recording systems in a lot of the states, only allow you to list one race and one ethnicity for an individual, versus kind of what we know now is that people's identities are unique and are multi-layered, and we should be offering the opportunity for these individuals to list all the different components that they self-identify as, so that we can then better understand that population. I think one of the things that we're really proud of in the city of Alexandria and with our health department is, while we've recognized that we have a gap in the data and our data is not disaggregated, we're looking at it in large chunks, we are now working with external partners like our city demographer, as well as some of the nonprofits that work in our city, to better get other anchoring data to then start disaggregating the medical data that we have and the population health data that we have. But the other thing that we're doing that I think we're excited about is that we're using our funding to drive that change. When we purchase data from population health vendors, we're making sure that they also have much more granular data for us to purchase and then utilize in our analysis. We can't collect all the data ourselves, and there are other organizations and companies that are doing it. And we're going to use the money that we spend as a health department and as a governmental agency to drive that as a need prior to the purchase. And I think that's something that we're incredibly proud of at the health department, that not only is it the work that we're doing, but also the money that we're spending. Because a lot of times these efforts can be short-circuited if you're not going to spend money on it. So you have to spend your money where your values are.
And Alicia, I know that you've been in this space for a long time advocating for this, and with your work with the UCLA Data Policy Labs.
Thank you. I can probably talk for days about why our community is so passionate about data disaggregation work. I don't think I need to re-emphasize that for those of you that are in the room. I think you already know how important that is to our communities. But I have four main best practices that I think that has worked for us in our work to advocate for disaggregated data, particularly for our NHPI communities. Number one is absolutely building relationships with public health agencies and other allies. We saw during the pandemic that the existing relationships we had with county agencies really helped us make sure that our COVID data was disaggregated at the county level. One example is that California DPH have a threshold for populations for data that they report publicly, and it had to be over 20,000 people. So if you know our community in California, the only county that had NHPI population over 20,000 was LA County, which is the county with the largest population of us. And so that would have meant that none of our other counties would report, or they actually didn't report our data publicly, and including LA County. But we had existing relationships with many of our counties that have large populations, and it took community organizations actually talking to county agencies one by one to ask them to disaggregate our data. And that was based on relationships that many of our community-based organizations had on the ground with county agencies. And so relationships with county agencies are key in being able to advocate for not just data disaggregation, but other resources that communities need. And then also building relationship with other allies. I say we as in many of our referencing work in California, but I know that many of our other organizations in other states utilize the same strategies, is building relationship with other allies. We have really worked closely with many Southeast Asian organizations, also just Asian American and Pacific Islander serving organizations to elevate our issues. And so an example is there was a bill that went through the California legislature to expand subgroups that are Asian American and Pacific Islander, and we partner with CRAC to actually co-author the bill and advocate for the bill, and it was passed. And now the implementation is another challenge, and we're partnering with academic institutions and other AAPI organizations to make sure that the implementation is also done well. So building relationships is really important. Also relationships with legislators. go a long way. And whether that's at the state level or at the federal level, I think that's why APAICS exists, right? Is to make sure that there are relationships with our representatives and also representatives from our community. Anticipating challenges and having solutions for them, knowing that something like this will always cost more money, or the reason will always be that it costs too much money. But working with institutions to maybe get an idea of what the cost is, and work with philanthropy and funding agencies to see whether there's a way to support it. And so having strategies already in place as you're advocating for your needs. And then lastly, supporting building data infrastructure. That's something that we did with the establishment of the NHPI Data Policy Lab, is that we weren't going to wait around for data to be made available to us. We went and found ways to make the data available to our community, because we were really looking at we initiated that because a reporter came to us and asked us whether it was true that our community's case and death rates were higher than any other racial ethnic groups. And so we're like, where's the data? We want to make sure that our data was available. CDC didn't have anything in place. We looked through state, that was slow. And so it was really pulling together relationships with UCLA and other researchers to help establish the lab so that there's one body that's focused on building that infrastructure for our community. So those are four of the best practices that I want to share for ensuring that data disaggregation is done to the best interest of communities that are in need.
Thank you so much. These are such important real-lived experiences and strategies that all of you are engaging in. And in our own work in New York City and New York State, working with our Department of Health there, one of the things that we had an opportunity to do and work on with the Coalition for Children, Asian American Children and Families, is to focus on that advocacy, to build those partnerships between my academic institution, community organizations, and governmental agencies. And I think one of the small lessons learned that we took from that whole opportunity was in collecting the data and creating more disaggregated categories. We knew that we wouldn't be able to list all the groups, but the default is always to include the other category for people to check off. But instead of other, what we heard from our community partners and doing focus groups with actual residents and members was, don't put in an other category, put in not listed, and allow people to fill in, because they can see that they're not being represented, and there should be an opportunity. They are not other, and we should stop othering other populations. I just recognizing that Alicia, you already talked about like some of the partnerships that are so important to getting some of these work done. I want to open it up and talk about other opportunities that the government, private sector, and academia can work on together in moving these forward. And Sean, I wanted to turn to you.
So I think I don't want to repeat some of the things that Alicia brought up, and but one of the parts that I really wanted to emphasize that could be important for the folks in this room, public health practitioners, and also like our corporate partners like in pharma, is recognizing that even outside of the established partnerships, having other stakeholders in mind when you're doing your work can be super helpful. And one of the examples that I had prepped is that when the pandemic was occurring and when we were having conversations, and we being the FDA and the CDC was having conversations about their approvals for the different vaccines, one of the parts that was brought up that differentiated the different vaccines was the diversity in the clinical trials, and talking about one of the vaccines that had a much more diverse population that it was tested on and had higher, had more detailed results based off of that. And so what we could do in public health was, when we saw that and we could see the documentation was in the clinical trial results that were submitted to the FDA, we were able to use that and leverage that into talking points to talk to our vaccine hesitant populations, especially our underrepresented and underserved populations. The folks that were going to get the vaccines no matter what came to us. the folks that were concerned, we had to go to them and we had to talk to them and we had to understand where their fears were coming from. And to the point that they felt like they were unlisted and othered and just ignored, recognizing that the corporate partners, some of the corporate partners had recognized that and were working towards that. We've talked about the Diverse Clinical Trials Act, and I think that's very important. But the other part that's super important that is that just got the rule just got issued by the FDA is the fact that these could be distributed. A lot of times clinical trials exist around a large medical center because you can find a captive population there. But in reality, what we need to be doing is capturing our populations, our diverse populations, our AAPI populations that don't live in cities. Because not all Asian Americans and Pacific Islanders live in big cities. We are across the country and we need to be part of these clinical trials that occur in suburban settings and in rural settings, and we should be part of those clinical trials and part of that conversation so that in public health we can talk about how we are part of the conversation. Public health is all about health equity. We exist to serve the people that can't go to traditional doctors. We exist to serve the people that can't afford to go to traditional doctors, and so we look to our other partners to kind of understand that and give us the ammunition that we need to continue to do that.
Dr. Fenton?
Yes, thank you. So, like I mentioned before, I run a nonprofit organization, the Dallas Obesity Society, and we're really focused on how do we talk about obesity as the chronic medical disease that it is, and more recently, really framing this in the context of treating obesity to treat the underlying metabolic diseases. This really is a big paradigm shift in medicine. So again, treatment of obesity is not about vanity, but really about disease treatment and prevention. Specifically for Asians currently, the medications that we have out there for weight management, unfortunately, are limited to those with a BMI greater than 30 or greater than 27 with comorbid conditions, which means, again, for Asians, we're not going to have access to those medications that for many can be, life-extending, reducing for diseases. More specifically, the newest medications that we now have for weight management, this is semaglutide and liraglutide. They have really fantastic weight loss percentages averaging up to 15%. This would, again, really transform people's lives and health. But unfortunately, currently where things are with the FDA indications, Asians are not able to have access to this unless they unfortunately develop diabetes or gain weight up to a BMI of 27 or higher. So my hope is that the government and private sectors work together on increasing access to care, increasing access to medications, such that the indications may actually include metabolic syndrome. Thank you.
I feel like I've been talking a lot. Just so I have some things written down, but I'll just touch on a couple of things. I think the transparency and accountability in the work that government and private institutions do together to address equity is really valuable in being able to see whether there's a way for communities to contribute to processes to make things more equitable. And I know that I've been talking about data disaggregation a lot, but in my view, there's no equity in any other area unless there's data equity to justify the needs of communities that are marginalized and vulnerable. And so I think there's opportunities in the private sector to disaggregate data to the standards, at the very least, that OMB mandates. Where we're having issues making sure that happens in the federal government. But, there doesn't need to be a law for private sector to be able to adopt minimum standards that OMB provides. And that would be really important and will go a long way for our communities to be able to have the data that it needs. Kaiser Permanente has done this a lot recently in some of their reports that they report disaggregated Asian American subpopulation as well as Native Hawaiian and Pacific Islander subpopulation, and being that they are frontline data collectors of our communities, that has been really valuable to the work we're doing. And I think also just partnership for greater funding and investment in smaller, vulnerable, and marginalized communities.
Wonderful. I want to open it up to everyone to take advantage of this incredible panel. So if you have questions, please raise your hand, and there's a microphone in the back. There's a question over here. Oh, sorry.
Well, first, thank you so much to the extraordinary panel. My name is Ruben. I'm a college student at George Washington University. My question is specifically to Dr. Vinton. I've read a lot, or I know there's been a lot written about health equity, particularly since 2020. And my understanding is that one area that's gotten a lot of attention has specifically been the BMI because of concerns regarding racial bias that's present within it, as well as its history and its use during the times of colonialism. And so I'm kind of curious from your perspective as a practitioner and founder, how you interact with that, and if that's something that you're able to kind of take a position on as a practitioner, or if it's something that you kind of feel is sort of a fixed constraint that you need to deal with.
That's an excellent question. Thank you for asking that. So I would say really BMI is a very rudimentary tool that we've used to diagnose and identify obesity. But truly, obesity is the disease of excess fat, not about the BMI chart. I tell patients this all the time, which also leads to the question of what should my goal weight be? And if we look at the BMI chart, again, for Asians especially, being normal weight may still be high risk for metabolic disease. You may still have metabolic disease at a BMI of 23 or even 22. So my hope is that eventually we will pull away from using the BMI so much, but currently we just don't have other great tools unless everyone's able to get a body composition scale at their general practitioner's office to check for body composition, your body fat mass, your skeletal muscle mass. Until we get there, I think it's very, very difficult to be able to have any other tools to answer that question of do you have adiposity or not.
Thank you.
Thank you. Ricardo Sanchez with Bristol Myers Squibb. Mainly to you, Nishith. So you talked about how how patients were having a really difficult time when it came to diversity because certain things were being looked at as a tax on them. On the manufacturer side, which Bristol Myers Squibb, but we're in that space. We have a tough time with that as well because when we try to make it easier for patients to get to these clinical trials, whether it is with, let's say transportation vouchers or let's say an iPad so they can meet their doctors through telehealth, then we get dinged for incentivizing, trying to get them more into like our product, which is not really what we're trying to do. We're really trying to just make it as easy as possible for the patient so that we can have this diversity. As all of us know, our communities, me being Latino, it's hard to get to these places because we have to work a lot of the times. We don't have this luxury of missing work to do a clinical trial and X, Y, Z reasons. What are some of, how can we fix this? So what are some ideas? And I know we can go like down this rabbit hole, right? But some more of the high level stuff.
Well, can't we? I'm just kidding. No. No, I mean, and Sean mentioned it also. It's like we have people in rural communities. Telehealth is crucial for treatment, let alone for trials. And that's part of one of the things I mentioned. We're working on the second phase of the Diverse Act that includes access from that perspective also. And that's on me for not forgetting the geographic diversity, but that's huge. Rural communities are so underrepresented across the spectrum, especially rural communities of color are very, very underrepresented. So part of that, the tax safe harbor, if you will, includes access to tools like iPads and other telehealth necessities, really. And it would create, it's a necessity. It's not an incentive necessarily. It is an incentive in a good way, but not like you're not bribing somebody to participate in a clinical trial. You're trying to get participation to make the drug more effective, safer, and better for everyone across the country and really the world for a lot of companies. So I don't know if I really answered your question or repeated what I said earlier, but it's the same thing. It's all part of the same, two sides of the same coin, I guess is the best way to put it.
Can I add to that? I think one of the other parts that we've seen about clinical trial participation, but then clinical trial participation adherence. So recruiting participants, but then ensuring that they continue to adhere to the trial standards over an extended period of time. There needs to be a more nuanced conversation between the investigators as well as the population about what does it mean to stay adherent and to stay, to continue the documentation both in the in-person visits as well as the intermediary time. One of the things that we've seen when we're working with doing our own research studies within the Department of Health is that not only are we initiating contact to measure the outcomes of the study, but in the intervening times, we're initiating contact to build a relationship to continue the desire for trial adherence. So I think one of the things that has to shift when you're talking to diverse communities is that those conversations need to have a different tone for trial adherence and standard and like the standards of the trial are continued to be upheld so that that data continues to stay valid. It's just one of those things where I think as this effort matures, that'll get integrated, but I think the first movers are already implementing that when they're recruiting diverse populations.
So I'm mindful that we have 5 minutes left, and so I wanted to move down the line and ask you all to share a takeaway that you want to share with the audience on how we work towards advancing health equity for our Native Hawaiian, Pacific Islander, and Asian American communities. Sean, do you want to start?
All right.
What's your one takeaway?
I think my one takeaway is that I think, and I don't mean to steal Alici's thunder, but I think we have to continue to take the lessons learned from COVID and continue to advocate for the funding of infrastructure to continue to advance over health equity. So I think a lot of that's a loaded term. I think a lot of the health departments and community health operators that were reaching out to these underserved populations to ensure that they had access to testing and access to vaccinations during the pandemic, we should continue to empower them with both the capital assets as well as the technology assets to continue that outreach. Because for these populations, especially the underserved populations, the Asian American, Pacific Islander populations, we have to go to them. And part of that is understanding and doing the geospatial analysis and then giving our community health workers the cultural competency training as well as access to language tools such that we're having conversations in native languages rather than trying to force a conversation in English because that's where the medical community is. And so that's something that we at the Public Health Department are trying to do and continue to need support at the federal level, at the state level, and at the local level to get to these populations in need.
So my closing thoughts, obesity is absolutely a chronic medical disease condition, and specifically in Asians, there appears to be a greater disproportionate amount of metabolic diseases. I would say the good news is that it's been well documented and well shown that 10% weight loss can actually have very, very significant health impacts and improvements. So I think the real challenge here is increasing awareness of this disease in Asians and also then for treatment options.
Thanks. And since Sean basically already said my takeaway, thank you, Sean. I want to take this time to acknowledge some folks that are in the room that have partnered with our communities and continue to champion the work that we're doing, particularly Dr. Kamanaʻapono Crab, who is a mentor to me, and the work that he's doing on behalf of the NHPI community, or Native Hawaiian community specifically from Hawaii, and continuing to carry the torch there with the work he's doing with Health Forum. Jeff from APCHO, Manju from Equity Alliance. Thank you for continuing to be in the room on behalf of those that are not here, on behalf of our elders that have gone on, that you've held space for in the many years we've worked together. And then lastly, please download the NHPI Data Policy Platform. Many of you are familiar with the policy platform. This is a data policy platform that is specifically in the interest of NHPI populations. But I will tell you that what is in that document will also speak for many other of our communities. It's bit.ly NHPI Data Policy Platform, all lowercase. It's work that we did with communities across the country in Hawaii, and it also includes our top 10 issue areas, along with 3 special consideration populations. Thank you.
And I'll just follow up by saying, we can't give up. We can't let up. We've started down this path of improvements, and some of us work in organizations and spaces where we can do this internally and with our organizations. But even if you don't, everyone has a voice. Everyone has the opportunity to express their thoughts to their legislators, to the policymakers. And government isn't the end-all be-all, but government spends a lot of money on healthcare and has a lot of influence because of that. So letting your elected officials know that you want to see this breakdown in data disaggregation, especially, like that's OMB drives a lot through the regulations, and especially in that medical space. So letting your legislators and your elected officials know you want to drive this, continue down this path, drive this forward, is key to making sure that we don't get forgotten, overlooked, or moving on to the next crisis or next shiny object that drives everyone's attention away from what's so crucial for our communities.
So we are on time. You guys are amazing, and our panelists are amazing. So thank you all for coming. I hope you take advantage of the rest of the summit.